delay that we had to face. There were some technical issues. ये Apple का हमेशा फंडा चलता रहता है. Okay, well, so first take home thing is that as I interact with students, I understand that questions were too much integrated. और मेरे तरफ बहुत कम क्वेश्चंस आए saying कि हाँ ये मेडिसिन का क्वेश्चन था, बट बहुत से फिजियो, एनाटॉमी, बायोकेमिस्ट्री के क्वेश्चन में मेडिसिन इंटीग्रेटेड था या वाइस वर्सा, मतलब मेडिसिन के क्वेश्चन में बेसिक साइंसेस पर इंटीग्रेटेड. जितने भी मेरे पास मिले हैं विच आर नॉट बीइंग टेकन अप बाय माय फिजियो, बायोकेमिस्ट्री और पैथोलॉजी और फार्माकोलॉजी फैकल्टी, आई विल ट्राई टू डिस्कस. आपके पास जो भी क्वेश्चंस है आप मुझे शेयर कर सकते हो. इफ़ यू हैव डाउट्स अबाउट द पॉसिबल आंसर्स, आई विल बी अवेलेबल थ्रू टेलीग्राम एंड वी विल डिस्कस फॉर श्योर. Okay, so we'll start with the first question. I understand there was a question. Hello. ठीक है ठीक है ठीक है ठीक है. Okay. Combine all the essential questions from paper 1 and paper 2. I will try to be crisp, and most important objective is to give you the answers rather than trying to discuss the whole fundamental concepts. वो हमने किया है वीडियो लेक्चर्स में भी और रैपिड रिवीजन में भी एंड थ्रू सेवरल यूट्यूब सेशंस. ओके, एक दिक्कत थी दैट वॉट एवर क्वेश्चंस दैट स्टूडेंट्स वेर शेयरिंग, वेरी फ्यू क्वेश्चंस वेर डायरेक्टेड टुवर्ड्स मेडिसिन. तब सबका कहना यही था कि सर इतने इंटीग्रेटेड थे कि कौन सा मेडिसिन का है और कौन सा बेसिक साइंस का है पता लगाना मुश्किल ही था. तो जो भी क्वेश्चंस मेरे पास आए हैं आई विल ट्राई टू प्रोवाइड द आंसर्स फॉर यू. सो दिस इज द फर्स्ट क्वेश्चन दैट आई एम टेकिंग अप, एंड एज आई अंडरस्टैंड दैट देयर वाज वन क्वेश्चन, थोड़ा सा शायद लेंदी था, क्लिनिकली ओरिएंटेड था, विच वाज टॉकिंग अबाउट डेंगू. मोस्ट ऑफ द स्टूडेंट्स टोल्ड मी दैट द क्लिनिकल पिक्चर वाज सजेस्टिव ऑफ डेंगू हेमरेजिक फीवर, and the essence of the question was this. So in the question essentially we were trying to see what is the parameter that is useful for the prognostication in that case. So मेरा पहला point क्या है, is it the डेंगू हेमरेजिक फीवर उसके प्रोग्नोसिस के लिए हमको कोई पैरामीटर डिसाइड करना था या जनरली डेंगू के लिए. सो रूल नंबर 1, डेंगू के लिए फॉर प्रोग्नोसिस ऑफ डेंगू, whether it is dengue fever, dengue hemorrhagic fever or dengue shock syndrome, it does not matter. We primarily rely on the single most important prognostic factor. So now tell me, what do you think would be that answer? Is it going to be platelets, WBC count? चेक कर लीजिए फिर मैं स्टार्ट करूंगा, नहीं तो स्टूडेंट्स को भी दिक्कत होगी. स्विमिंग फाइन, ठीक है ठीक है. So guys, humble apologies, a lot of technical issues going on. So question number 1 about dengue. बहुत स्टूडेंट्स ने टाइम स्पेंड किया ट्राइंग टू आइडेंटिफाई कि ये डेंगू हेमरेजिक फीवर है या डेंगू फीवर है या डेंगू शॉक सिंड्रोम है. डजंट मैटर. In every patient of dengue, as a physician, my biggest worry is, will I lose the patient? And if I'm losing the patient, what is going to be the most common cause? It is not the platelet count going low and bleeding. That can cause mortality in some cases, but majority of the cases die because of dengue shock syndrome. Shock क्यों हो रहा है? Because of the capillary injury. So dengue leads to capillary injury, and when there is capillary injury, there is leaking of fluid from the blood, from the plasma. So fluid from plasma shifts into third spaces. What do I mean by third spaces? Your pleural cavity, peritoneal cavity, those are third spaces. So because of that you can get ascites in patients with dengue, you can get pleural effusion in patients with dengue. तो अगर प्लाज्मा से फ्लूइड शिफ्ट हो रहा है तो what will happen to the plasma volume? That decreases and patient can get into shock and die. तो अगर मुझे आइडेंटिफाई करना है प्लाज्मा वॉल्यूम डिक्रीज हो रहा है इंक्रीज हो रहा है, इनमें से कौन सा पैरामीटर इज गोइंग टू बी हेल्पफुल फॉर मी? Which of these parameter is going to be helpful for me to understand whether patient is leaking fluid from the plasma into the third spaces? Obviously hematocrit, right? So अगर मैं blood से पानी निकालने लगूंगा तो hematocrit will start increasing. So rising hematocrit in any patient with dengue is a danger sign. It is a red flag sign. So that is why for this question answer will be hematocrit. So 55% hematocrit is a very high hematocrit. That definitely proclaims that there is a possibility of poor prognosis. So in the question, in the patient's stem, they had mentioned that the hematocrit is 55%. It is definitely high, and it is one risk factor. It is telling us that he is losing fluid from his plasma into third spaces, and he is slowly inching towards dengue shock syndrome. So hematocrit would be the answer in this question. Okay. Okay, good. So for prognostication, hematocrit is the first important parameter, then आता है platelet count. Okay. Now there was one more question on the dyslipidemia. The patient was on dyslipidemia and he was started on some medication. After that, he started developing flushing, hyperglycemia, and hepatotoxicity. Which drug is responsible? So the moment they say flushing, I think we all know the answer. The answer will be niacin. The answer will be niacin. But you should also remember that statins are known to induce hyperglycemia. Niacin can also cause hyperglycemia, but statins can also cause hyperglycemia. You should be aware of that, but flushing is not caused by statins. So flushing was the clincher and the answer would be niacin. And just for the record, we should also be aware that statins causes muscle injury. Statin induced myopathy is well known to occur. Okay. Then this was one question. Can you help me to create a better stem? Is that how the question appeared? Murmur of 𝐿 will increase on hand grip, Valsalva maneuver, squatting, or sitting and bending forward. Okay, so what is the 𝐿? 𝐿 is a inherited condition where you have asymmetric septal left ventricular hypertrophy that kind of creates obstruction to the ejection of blood from left ventricle. So ejection of blood from left ventricle gets interrupted by this asymmetric septal hypertrophy. That is why you get this classical banana shaped left ventricle in hypertrophic cardiomyopathy. So when we assess the murmurs and do these all maneuvers, first point we do is we will do some maneuvers which will increase the venous return to heart or decrease the venous return to heart, and we'll see what happens to the murmur. Normally maneuvers that increase the venous return to heart will increase most of the murmurs, because across a valve अगर blood flow ज़्यादा होता है तो murmur ज़्यादा होता है. So if venous return increases, blood flow increases, murmur increases. So rule is that all the murmurs increase on maneuvers that increase the venous return except HOCM and mitral valve prolapse. So if you increase venous return, all murmurs increase. But HOCM and mitral valve prolapse murmurs decrease. Why that happens? Because if I increase the venous return, I fill the left ventricle. So left ventricle को भर दिया, so then as the left ventricle fills, this interventricular septum will move away, right? Left ventricle ऐसे खुलने लगेगा. So जो obstruction ये interventricular septum कर रहा है वो हट जाएगा and obstruction will decrease. The murmur will the murmur, what will happen to the murmur? The murmur will decrease. And the vice versa is true. The maneuvers that decrease the venous return, for all murmurs it will increase. All murmurs increase. The maneuvers that decrease the venous return, all murmurs will decrease because flow decrease हो रहा है. लेकिन HOCM और mitral valve prolapse का जो murmur है वो increase होता है. ऐसा क्यों होता है? If I fill the left ventricle less, then the two walls of the ventricle will come closer. So interventricular septum will move more closer and the obstruction becomes much more profound, right? So now tell me, among the given maneuvers, is there anything that decreases the venous return? If I decrease the venous return, the murmur of HOCM increases. So is there anything that decreases the venous return here? It is the Valsalva, right? Valsalva decreases the venous return, and that will be the answer. When we squat, we contract our calf muscles and push the blood in the veins of the lower limbs towards the heart. So we increase the venous return. So squatting increases the venous return. Okay. Sitting and bending forward can only make the murmur more appreciable. It does not do anything with the murmur intensity. Hand grip generally increases regurgitant murmurs. Regurgitant murmurs of the left side. What are those? Mainly aortic regurgitation and mitral regurgitation murmurs increase on hand grip exercise. So for this question, the answer will be clearly option B, Valsalva maneuver. 𝐒𝐿 𝐂𝐿, that's good. If medicine was easy, I'm more than pleased. I know medicine was underrepresented this time. Maybe next time they will overrepresent this subject. Illogically, kabhi they keep on adding more questions from one subject and ignoring the other. So this time it was medicine's time. So जिन्होंने medicine कम पढ़ा था, they were lucky, and those who were unfortunately had studied surgery or OBG less, they were kind of unlucky. Okay, now I guess there was one question on the JVP and atrial fibrillation, right? Can anybody help me with the options? 𝐒𝐂𝐈𝐀 चरकुमल्ली absolutely right except HOCM and MVP. Good. Okay. Was there a question on JVP and atrial fibrillation? So if they're asking you what happens to JVP on atrial fibrillation, that was a pretty straightforward and a basic question. So in the JVP, atrial contraction is represented by A waves, right? So A waves represent on the JVP, A waves represent atrial systole or atrial contraction. Basically, अगर cardiac cycle से compare करूँ तो it is representing the active filling phase of the ventricular diastole. एट्रियल फिब्रिलेशन में क्या होता है, एट्रिया आर ओनली शेकिंग एंड नॉट कॉन्ट्रैक्टिंग. अगर वो शेक नहीं कर रहे हैं तो वो कॉन्ट्रैक्ट नहीं कर रहे हैं, कॉन्ट्रैक्ट नहीं कर रहे हैं तो ए वेव क्या होगा, एब्सेंट होगा. दैट्स अ सिंपल एंड अ स्ट्रेट फॉरवर्ड क्वेश्चन. सो वी वुड हैव हैड एब्सेंट ए वेव्स इन पेशेंट्स विथ atrial fibrillation. So that was pretty straightforward. Okay, so I guess we had one similar question. So absent A wave is the standard direct straightforward question there, right? The straightforward answer. Okay, so was there anything about the heart sounds also on the atrial fibrillation? What happens to the heart sounds in atrial fibrillation? Main change that happens to the heart sounds in atrial fibrillation is you will have varying intensity of S1 because जो atria का activity है वो varying है, तो intensity of S1 will be varying. Loud S1 you get in mitral stenosis, soft S1 in mitral regurgitation, varying intensity of S1 in atrial fibrillation. Okay, loud P2 does not directly have any relationship with atrial fibrillation, but most conditions where we can get atrial fibrillation, patients may have pulmonary hypertension that might cause loud P2, but no direct link per se. Okay, so there was one more question. Okay, so no relationship with the loud P2 directly, but pulmonary hypertension, see, mitral stenosis is one of the risk factor for atrial fibrillation. Mitral stenosis में eventually pulmonary hypertension होता है, तो atrial fibrillation भी होता है. So in those cases, yes, we do see the atrial fibrillation with pulmonary hypertension. There we can have loud P2. So loud P2, always think of pulmonary hypertension. Okay, so in this question, we have a patient with abdominal pain. Cannon A waves, as you know, it is seen in patients with AV dissociation. मतलब एट्रिया और वेंट्रिकल का जो कॉन्ट्रैक्शन है वो साइमल्टेनियसली हो रहा है. नॉर्मली क्या होता है, एट्रिया पहले सिस्टोल में, उस टाइम वेंट्रिकल डायस्टोल में, जब वेंट्रिकल सिस्टोल में एट्रिया विल बी इन डायस्टोल, बट दोनों एक टाइम पे कॉन्ट्रैक्ट करते हैं तो एट्रिया में प्रेशर बहुत बढ़ जाता है. सो वी सी कैनन वेव्स व्हेन एवी डिसोसिएशन हैपेंस लाइक इन वेंट्रिकुलर टेकिकार्डिया और हार्ट ब्लॉक्स, कंप्लीट हार्ट ब्लॉक. Okay, now another question was about abdominal pain. So patient had abdominal pain radiating to back for 5 days and report में शायद बताया गया था कि amylase and lipase were increased in number and this patient was given 2 liters of normal saline over 24 hours and then patient started complaining of shortness of breath and the chest x-ray was done which showed possibly pulmonary edema. The chest x-ray was suggestive of pulmonary edema. I guess it was an image based question and I'm very sure all of you recognize that it was a pulmonary edema. अब हमको इनमें से ऑप्शन पिक करना है, right? What is the cause? Was it cardiogenic pulmonary edema? Was it miliary TB, ARDS or pulmonary embolism? Okay, so the chest x-ray, obviously I have not received any image which is very closer to the actual image, तो अगर मिल जाता तो we could discuss more about it. So if you're saying it was looking like aspiration pneumonia, that is a possibility, but option में तो नहीं है ना aspiration pneumonia का कोई option, direct option तो नहीं है, तो fine. Non cardiogenic ARDS mention नहीं था option में, ठीक है, so we will take that out. So was there cardiogenic pulmonary edema and non cardiogenic pulmonary edema as the option? Okay, see, this is certainly not pulmonary embolism. First thing is that the clinical story is suggestive of pancreatitis, and you all know pancreatitis has high mortality, and one of the important cause for pancreatitis mortality, number one cause for mortality is shock, right? Number one cause for mortality is shock. Number two cause for mortality is development of ARDS. So pancreatitis is an inflammatory event which is known to cause ARDS. तो पहले उसी बेसिस पे हमको ARDS सस्पेक्ट करना है, बट अदर पॉसिबिलिटीज को भी कंसिडर करना है. मिलियरी टीबी का ऑप्शन नहीं है, नॉट द राइट आंसर. एंड अगर कार्डियोजेनिक पल्मोनरी एडिमा है या फ्लूइड ओवरलोड से है तो दैट इज ऑल्सो नॉट द राइट आंसर. फ्लूइड ओवरलोड क्यों राइट आंसर नहीं है? फर्स्ट ऑफ ऑल पैंक्रेटाइटिस में फ्लूइड डेफिसिट होता है. वी नीड टू गिव गुड अमाउंट ऑफ फ्लूइड. 2 liters of fluid in 24 hours will not cause fluid overload. That would not be the reason for pulmonary edema until and unless patient has already pre-existing heart failure, right? Pulmonary embolism in pancreatitis, yes, pancreatitis is a risk factor for pulmonary embolism because pancreatitis severe often makes patient get confined to bed in the hospital. Immobility can cause DVT. From DVT you can have pulmonary embolism. बट एक्सरे से पल्मोनरी एम्बोलिज्म डायग्नोसिस जनरली नहीं होता है. एंड इवन इफ यू हैव टू डायग्नोस दे शुड हैव गिवन दोज फोकल ओलिगेमिया ऑन द चेस्ट एक्सरे और द अब्रप्ट कट ऑफ द पल्मोनरी आर्टरी as the Westermarck sign. So if those findings are not there, probably it is not pulmonary embolism either. So obviously we could have gone with the non-cardiogenic pulmonary edema as the answer. अगर ARDX डायरेक्टली दिया गया था तो that would have been our answer. Ravish Ashwat, very good. So if they are not given a wedge-shaped opacity or the focal oligemia, then that is also ruled out. So if X-ray से हम convinced है कि there is pulmonary edema, and from the story, then I am very much convinced that this question was about non-cardiogenic pulmonary edema. Okay, so these are the only few questions that I could collect from medicine. एक था कि medicine से शायद directly ज़्यादा कुछ नहीं था, और जो भी कुछ था, it was probably integrated with other subjects. So my other subject colleagues will be bringing in more questions to you. एक week के बाद में we will gather a little more detailed and refined questions, and we will come back with a recorded videos which will be available on the PW Medit app for. Hypertension with ECG. Okay, what all was given? Atrial fibrillation management के basis पे question था. तो what were they asking? What were they? Okay, so let us take that question. Atrial fibrillation का question क्या था? I presume कि आपका diagnosis of atrial fibrillation correct है. And what were they asking? Had they mentioned the blood pressure of the patient? Aspiration pneumonia का question, is it? Are you referring to the question that we picked up as non-cardiogenic pulmonary edema, और ये अलग question था? ये अलग क्वेश्चन था या that is the same question as the non-cardiogenic pulmonary edema that we picked up? Okay, so they had mentioned irregular pulse. Okay, got it. So based on that we have concluded that this patient has atrial fibrillation. Okay, pancreatitis वाले में ही. Okay, so that pancreatitis question, then I will be able to give you a better answer if you can send me a closest looking X-ray from the Google. जो X-ray जैसे एग्जाम में था वैसे ही दिखने वाला, because if he is having recurrent vomiting which is common in pancreatitis, तो aspiration भी हो सकता है. But remember, aspiration can also trigger ARDS. दोनों possibility हैं. अगर सिर्फ opacity right lower zone में था तो you can take it as aspiration. Bilateral opacity दिख रहा था तो it is non-cardiogenic pulmonary edema. Even if aspiration has triggered it, we have landed up in ARDS now. That's clear. Okay, so atrial fibrillation में choose incorrect statement था, right? Okay, so the child one, obviously drug of choice will remain same, adenosine for the PSVT, but the child one I will leave it to Sharad Balaji sir, because the dosing is going to be different. Adults we will start with 6 milligram, then go to 12, and if not helping, fine. JVP in pulmonary hypertension or pulmonary stenosis, right? You're saying JVP in pulmonary hypertension. If you're thinking of JVP in pulmonary hypertension or even pulmonic stenosis, it is all going to be same. What is that? If this is my right atrium, right ventricle, अगर pulmonary hypertension है या right ventricular hypertrophy है या pulmonic stenosis है, eventually right ventricular hypertrophy होने के बाद right ventricle की cavity छोटा हो जाता है, तो मुझे right atrium से right ventricle में blood transfer करने में दिक्कत होता है. तो जो A waves होते हैं, जब atria contract करेगा तो pressure अंदर बहुत बढ़ेगा, so you will get prominent or giant A waves. You will get prominent or giant A waves. Prominent or giant A waves. हाँ, so if it was a question about a patient with atrial fibrillation and loud P2, Arju, can you share that question stem properly with me? I'll come back with the answer to you. So if it is simple pulmonary hypertension or the pulmonic stenosis, you will have the giant A waves. But atrial fibrillation जब तक है A waves absent रहेंगे even if you have the pulmonary hypertension. Even if you have the pulmonary hypertension, because atria contract करने से A wave बनता है. Atria contract नहीं करेगा तो A wave नहीं बनेगा. Okay, so that's all I think we can recall. Please connect with me on the Telegram and let us continue the discussion there. Cardiac tamponade का क्वेश्चन क्या था? Is it related to JVP or is it related to management? Okay, so guys, what we will do is I will take a break now and I will connect with you all on the Telegram. So what I would suggest now, atrial fibrillation even with pulmonary hypertension, go ahead with the absent A waves. That would be the right answer. Okay, so मैं stems और refine करके फिर एक बार we will connect. I have to pass on the patent to PSM faculty. He is waiting in line. So you can join with him for the PSM recall. We will connect again soon. Thank you guys. See you soon. Thank you.